Patients had no recurrent episodes. Case 4, the last case is called Hit Me While I'm Down. And this was a 50-year-old male who was hospitalized in October of 2009 for bilateral lower extremity DVTs and also a saddle pulmonary embolus, so it was affecting both branches of the pulmonary artery. Patient had a high D dimer on admission, like you would expect in somebody that has a pulmonary embolus. Patient's past medical history included alcoholic cirrhosis. They ran a whole panel of hypercoagulable testing, which is not recommended in somebody that's having an acute event, because you can see that the protein C, antigen and activity, and the protein S levels are all will be low in this situation because that's an acquired deficiency because the patient's actively clotting. But the other tests, like the factor V Leiden and the prothrombin gene, were normal, and those tests you can do in the acute episode. The patient was treated with intravenous heparin and thrombolytic therapy. They placed an intravenous inferior vena cava filter to prevent further pulmonary emboli from reaching the lungs. And the patient was then discharged on low molecular weight heparin and Coumadin, but then was admitted about 2 weeks later with weakness, diarrhea, and a swollen lower leg. His platelet count was only 36,000 when he was admitted, and it had been normal during the previous admission. It was at 211,000. They did a Doppler exam and showed that he now had a new thrombus of his lower leg that he had the previous DVT in. His other laboratory results showed this very low platelet count. His INR was 3.5, so he was getting plenty of Coumadin. He did not have a platelet antibody, so that was not explaining the low platelet count. And then they did a test for the heparin-induced platelet antibody, and it was 2.89, which is a very high result. Anything over 0.49 is considered positive. And so the diagnosis was heparin-induced thrombocytopenia, or HIT. Once they made this diagnosis, they stopped the low molecular weight heparin. They treated him with argatroban, and they continued this until his platelet count rose to over 150,000, and then they started him on Coumadin. Argatroban is a direct thrombin inhibitor, as opposed to heparin, which is an indirect thrombin inhibitor. It is FDA approved for prophylaxis and treatment of patients with heparin-induced thrombocytopenia, and you have to monitor the APTT. It has a very short half-life. The problem is that patients bleed when they're on this drug. There's no antidote to reverse it like there is with heparin. And that's why the cardiothoracic surgeons wrestle all the time with a patient with HIT that needs to have open heart surgery. They really don't like to have to switch them to argatroban because if the patient does start bleeding, it's very hard to control the bleeding. It's not like heparin where you can give more protamine. So the diagnostic criteria for HIT, I think this causes a lot of confusion, but there's pretty good studies showing that people with HIT have a drop in their platelet count below 150,000, and usually it's a more than 50% decrease from their platelet count before they were put on heparin. And the lower the count, the higher the risk they have of developing thrombosis. And if somebody that drops their platelet count 70 to 90% will have the highest risk. It usually occurs anywhere from 5 to 14 days after the initiation of heparin therapy, or if somebody's had heparin in the past, it can occur as fast as 1 to 3 days after re-exposure to heparin. It's always important to exclude other causes of a low platelet count, and hospitalized patients have a lot of other causes of a low platelet count. So things like splenomegaly, DIC, ITP, TTP, the antiphospholipid antibody syndrome, and other drugs all need to be excluded. And then you need to have a positive test for HIT, and in our hospital we use what's called the PF4 ELISA test. And it should be positive in almost all cases if they really have this syndrome. Major risk factors are being exposed to heparin for more than 5 days. It's a higher risk if you're on unfractionated heparin than if you're on low molecular weight heparin. It's much more common after surgery than it is in a medical patient, and it's more common in females than it is in males. I use this triangle to illustrate that there's a lot of people that will test positive for a heparin-induced platelet antibody. And there's a smaller percent of those that will then go on to develop thrombocytopenia, and there's even a smaller percent that will have both the antibody and a low platelet count that will then develop thrombosis. So I get calls all the time because a patient has a positive hit antibody, and then they want to know, is the patient really going to have a thrombosis? Well, or is that a false positive test? It's not a false positive test. They have been exposed to heparin in the past. They've made antibody to it, but it's probably just not a potent enough antibody to actually go on and cause the thrombosis. So people with hit antibodies, about 50% of them will develop venous thrombosis, more commonly deep vein thrombosis, and then pulmonary emboli, then adrenal artery thrombosis, and then cerebral vessel thrombosis. Some patients will develop arterial thrombosis, usually of an arm or a leg, occasionally involving the brain or the heart. Even a smaller percentage will develop DIC, like picture, and affect all their small blood vessels throughout the body. And some patients will actually develop skin lesions. It looks like an anaphylactoid type skin lesion due to heparin. Typically, in our case, you can see that the patient platelet count was very low, and then once they took the patient off the heparin and started them on the argatroban, that the count gradually went back up to 200,000. As far as why does this occur, well, heparin is a strongly charged molecule, and when it is in the circulation, it binds to the surface of the platelet, and it displaces this platelet factor 4 off the surface of the platelet. And then the heparin and the platelet factor 4 form a complex, an immune complex that goes throughout the circulation. An antibody will actually be formed into this complex because it's changed the structure of the platelet factor 4 antigen because it's now unfolded with heparin bound to it, and it's recognized as a foreign protein. Antibody binds to that. You get these immune complexes formed. The immune complexes then bind to the surface of the platelet, and then the spleen and the macrophage, just like we saw in the ITP case, they see these antibody-coated platelets and they remove them from the circulation. The other thing, though, that can happen is that when this antibody antigen complex binds to the platelet, it can actually activate the platelet and then cause it to undergo massive aggregation and cause thrombosis. There are a lot of different assays for this. I mentioned that we used this platelet factor 4 specific test. I just want to point out it's got a very high sensitivity, a little bit lower specificity. But this is the best screening test because it'll pick up just about every case of when the antibody is present. It doesn't mean, though, that if the patient has this, they're going to have thrombosis. The other test is the serotonin release assay, and it has one of the lowest sensitivities, but it has a much higher specificity. And the reason I point this out is what we do a lot of times, if we get a patient that has a positive hit antibody in our laboratory test, the doctor wants to know, is this an antibody that's really capable of causing thrombosis? Because I have to take this patient to surgery and I want to use heparin, we'll order the serotonin release assay. If it's negative, it's probably not a potent enough antibody to cause thrombosis, and it's okay to take that patient to surgery, expose them to heparin, and then immediately take them off heparin post-operatively. When we report out the platelet factor 4 heparin antibody, we report out the strength of the reaction and not just whether it's positive or negative. And I bring this up because you can see that if a patient has a result of 0.4 to 1, which is a very weakly reactive positive test, they only have a 5% chance of forming thrombosis. But if that assay comes back greater than 2.0, then it's greater than a 90% chance that that's going to be a really nasty actor and probably cause thrombosis. As far as these, I really need to cover all this. This is kind of arcane. But I just want to mention that these antibodies are transient, and unlike a lot of immune functions. And so if once you take a patient off heparin for about 100 days, the antibody will disappear. Of course, if you re-expose them, it can form again. It's also very tricky to diagnose this in a patient who's immunosuppressed, especially a transplant patient, because the antibody level may not be high enough for us to detect it. So as far as treating these patients, it's important to stop heparin, including low molecular weight heparin, switch them to an alternative anticoagulant. Argatroban and lepirudin are the two that are FDA approved for this indication. Then you can you want to correct their prolonged INR with vitamin K. You don't want to start warfarin until the patient's platelet count normalizes. If you do start it too quickly, you can cause gangrene of their limbs. And you want to avoid giving these patients platelet transfusions if at all possible, because you may trigger off thrombosis. So in summary, this is a patient who had one hereditary risk factor for venous thrombosis. The patient did develop deep vein thrombosis and pulmonary emboli, was treated with unfractionated heparin and low molecular weight heparin, developed the HIT antibody with thrombosis within 14 days of treatment. Then the heparin was stopped, and he was given thrombolytic therapy. His circulation was reestablished, and he was able to be discharged to a skilled nursing unit. And that's it. Any questions?